So I'm going to talk a little bit about increased incidence of allergy. It's been in the media a lot, and is it really a media hype, or is there some truth behind that? These are some recent journal or magazines that have talked about this rise in allergy in the past few years. So let's just look into this a little bit more. This is Canadian data from Health Canada looking at the prevalence of asthma in individuals above the age of 12, both men and women. And you can see every year there's a slight increase in the prevalence. And it tends to level off in 2000. But going back the previous 6 years, there has been a slight increase. And same kind of phenomenon has been seen in children aged 4 to 11. A very steady increase every year in the prevalence of asthma. And we're using asthma here kind of as an example of allergy. Now, this increase is not just seen here in Canada or North America, but is seen in Europe as well. This is a study from Aberdeen in the United Kingdom, and not just looking at asthma, which is the blue line. As you can see, a steady increase in the incidence over 35 years, quite dramatic since the 1990s, but also an increase in eczema, the orange line, and an increase in hay fever as well, seasonal rhinitis. And we're also seeing an increase in food allergy as well. So this is an American study, and over a 5-year period, there was a doubling of nut allergy seen in this study from 0.6% to 1.2%. And other studies, in Europe and that have also shown that there is a significant increase in food allergies. One thing about peanut allergy, it tends to be more unique or more prevalent in North America, and not so much in Europe or in Asia. And what's a bit surprising is that in Asia, particularly China, there's a huge consumption of peanut. So what is it? Well, they've looked at the protein in peanut that causes allergy, and in North America, how is peanut consumed? It's dry roasted in peanut butter, but it's dry roasted. Dry roasted is very high heat, and that actually makes the protein more allergenic. In China, how are peanuts eaten? Boiled or fried, exactly. And so the protein is not as allergenic. So that's part of the reason why we're seeing differences in different parts of the world. Okay? In Europe, they don't eat too much peanut butter. It's not a big thing. I think they like Nutella or something, but not so much peanut butter. Now, this is some interesting data from the World Health Organization. And again, we're going to use asthma kind of representing allergy. And you can see the countries that are shaded in pink and orange are kind of higher rates of asthma, prevalence of asthma. So Canada, the United States, parts of Europe such as England, Australia, and some other countries in Europe, you are seeing high rates of asthma. If you look at the blue and the green shaded countries, these have much lower rates of asthma. So Mexico, Africa, India, Russia, China, Indonesia. So we're seeing a higher rate in more westernized countries, kind of trending that way. It's not exact. You put a few holes in that theory, but the trend is more towards westernized countries having higher rates of asthma and allergy compared to non-westernized or kind of developing countries. And so it's been looked into a little bit more in depth as why is this the case. Both environment and diet have thought to be played a role. And also looking more relevant to diet is why the increase over so many years. In the past couple of decades, we are definitely seeing a significant rise in allergy and in manifestation of new allergy, as Dr. Schellenberg pointed out. And one of the main hypotheses has been the hygiene hypothesis that Dr. Schellenberg discussed briefly as well. Over the past few decades, we have a decline in family size, improved sanitation, higher standards of personal cleanliness. So all of that has led to less infections, particularly among children. And kind of very simply put, a child's immune system here in a westernized country, because it's not exposed to so many pathogens, is kind of sitting idle. And so what does it do? It kind of develops allergies. It has nothing else to do. Compared to a child, let's say, growing up in a developing country where they get more exposed to more infections, more pathogens, their immune system is very busy fighting those off, doesn't have time to develop allergy. But diet has also felt to be playing a role in this increase as well. And in the recent years, vitamin D has been implicated as one of the factors. Kind of more to explain why there may be a steady rise over the years. We tend to spend more time indoors. It's sunny outside, yet we're in here. Therefore, less exposure to the sun, less vitamin D production. Vitamin D is the sunshine vitamin. Also felt that there's a decreased intake from foods. So this deficiency in vitamin D, particularly among pregnant women, is felt to increase the risk of their offspring developing asthma and allergies. And there have been some epidemiological studies that have shown that women who have higher vitamin D intake have a much lower incidence of their children developing asthma. So this is an area that needs to be looked into a bit further. But it is some interesting data that's come out in the recent years. Antioxidants are also felt to play a role. And several studies have found beneficial effects, particularly from vitamin E intake. Less so from vitamin C. In the past, vitamin C was often touted, but studies are a bit weak with vitamin C. But the studies have particularly shown that the benefit may be more from the actual food source itself, not so much taking the supplement. But they've done some interventional studies, which is where they give people a supplement to see if there's a big difference. They haven't shown that. But when they look back at people whose diets have high amounts of these antioxidant foods, that's where they've shown the benefit. So the benefit may be more from eating the actual fresh fruit, the food itself, not so much taking a supplement pill. And then the fatty acids are also felt to play a role in this. Omega-6 fatty acids are more present in margarine and vegetables or vegetable oils, which we are consuming more of, fried foods, fast foods. And so this fatty acid has been shown to increase risk of developing allergies. And omega-3 is supposed to be a protective fatty acid, helps us decrease allergy and asthma. And that's present in oily fish, and there's been a decrease in the intake of that. So a lot of these dietary factors that may be playing a role. So there is an increase in allergies. We definitely have data suggesting that. And there's many theories out there as to why. And there's probably not one specific reason why there's an increase. It's probably multiple factors that are playing a role. Now I'm going to move on to just talking briefly about food allergies. And I'm going to focus more on just a direct food allergy. That's the type of food allergy that can lead to life-threatening or anaphylactic reactions. There are other forms of food allergy, and Dr. Schellenberg's already talked about the oral allergy syndrome and eosinophilic esophagitis. In about a third of children who have very bad eczema, foods can play a role in exacerbating their eczema. It's not the cause of it, but it can play an exacerbating role. But I'm going to focus more for the rest of the talk on just the direct food allergy. With direct food allergy, the reaction occurs very quickly. That's one of the key factors about this condition. It occurs within seconds or minutes of eating the food. Very fast onset. And it can involve a variety of systems in our body. It can involve our skin, where you can break out in hives. You can get swelling. Angioedema is the other term for that. You can get redness, flushing, a lot of itchiness. The breathing is affected, so you can get asthma symptoms, wheezing, chest tightness, coughing. You can get throat swelling. Stomach is affected, cramps, vomiting, diarrhea. And then our blood pressure can be affected. Blood pressure usually drops. You can get lightheaded, dizzy, and even pass out. And these reactions can be very dangerous and life-threatening. So a life-threatening allergic reaction is known as anaphylaxis. Okay? And this condition occurs very rapidly, and it's a very serious condition. Among children, this is data from about 6 years ago, so we are probably seeing higher rates now. This is a U.S. study, but we feel that in Canada it's approximately the similar values. Among young children, milk, egg, peanut account for a large number of allergies that we see. We can also see tree nut and seafood in them. Among the adults, it tends to be more the seafood and tree nuts, less so of milk and egg. And the reason for that is milk allergy tends to be outgrown. Usually after about 4 years of age, about 85% of children do outgrow a milk allergy. That's why we see, this significant decrease from young children to adults. Similar with egg as well. A lot of children do outgrow it. Okay? Peanut, unfortunately, is not one that is outgrown. That's why the prevalence is very similar between the two groups. Peanut allergy usually does start in childhood. So most adults who have it, it began in childhood. We don't commonly see adults developing new peanut allergy. It can happen, but it's not common. Recent studies have suggested about 15 to 20% of children who have milder peanut allergy can outgrow it. Okay? Tree nuts tend to occur more frequently in adults than in children. So this is kind of an allergy that can develop in adulthood. Okay? And also fish and shellfish. These tend to occur more in adulthood than in children. And part of the reason for shellfish is I don't think too many young children eat a lot of shellfish. I think it's more exposure to these as you get older. The overall prevalence of food allergy in young children is about 6%, and in adults about 3.7%. Now, these 6 foods, along with wheat, soy, and sesame seed, account for about 85% of all food allergies that we see. So these are by far the most common ones that we see. Now, you could potentially develop an allergy to any food, all right? And we do see some rare ones, but by far, these are the most common ones that we see. Now, there are other reactions that can occur to foods besides food allergic reactions. And Dr. Schellenberg kind of mentioned this earlier, that when we talk about allergy from a medical point of view, we're really talking about a very specific condition. A lot of people use the word allergy very loosely to describe any kind of reaction to anything. And from the medical point of view, that's not, correct. So with foods, you can have other reactions that are not allergic. So you can have intolerances. A very common example of this is lactose intolerance. Lactose is a sugar found in dairy products. There are some individuals who lack an enzyme called lactase in their gut that can help digest this sugar. They don't have it. It irritates their gut. They get a lot of stomach issues with this. Bloating, gas, diarrhea. Celiac disease. That's a condition where you're sensitive to gluten, a protein that's found in wheat. It can cause a lot of inflammation in the gut. Very much discomfort for the patient. But it's not considered an allergic reaction. It's more of a sensitivity. You can get pharmacological effects from foods. So caffeine is a common example of this. It can increase your heart rate, make you jittery, affect your sleep. But that's all a chemical property of caffeine. It's not necessarily an allergy to it. Tyramine in aged cheeses can cause migraine headaches. And there are a lot of other compounds in foods that can contribute to migraine headaches. Alcohol causes redness, flushing in some people, quite profound. Again, it's just a chemical property of the alcohol. It's not an actual allergy to it. And then food poisoning, again, it's a toxic reaction. There's no allergy going on here. Okay? So how do we diagnose a food allergy? History from the patient is the most important thing. As I said earlier, food allergy occurs very quickly. So when someone's had a reaction, we very focus in on what they're eating at that moment. If someone wakes up in the morning and has hives before they've even eaten anything, our suspicion for food allergy causing those hives is very low, because the food allergy occurs within seconds or minutes of eating the food. The longest we sometimes see it is 2 or 3 hours after, but not something you ate the night before or something you ate 2 days before. It's not going to cause a reaction. Okay. Once we get a history from the patient as to what they were eating, we want to focus in more on what possible food it could be. We do skin testing. Skin testing is a very simple, quick, easy way of diagnosing allergies. We do it for food allergy and environmental allergy. We can also do it to some drugs and latex. And all it involves is a very tiny poke on the surface of the skin, either the inner arm or the back, with a little plastic tip. Or you can put a drop on the arm of the allergen solution and then do the prick afterward. In this kind of testing, the tips are in a well that has a solution, so the solution is at the end of the tip. And that solution, basically, if it's a food, it contains, let's say, for example, peanut. It contains the protein from peanuts that we know people are allergic to. It's on there. It's in the solution. We expose a tiny part of the skin to that. If the individual has the allergy antibody, they will recognize that protein, And that allergy antibody will trigger the mast cells that are in the skin, and you get a little hive that develops, as in this picture right here. It's very localized, and it's a pretty safe way of assessing for someone, even someone who's got life-threatening peanut allergy. Okay? Sometimes we cannot do skin testing in someone who's got bad skin disease, a lot of eczema. It's very difficult to do skin testing, or they're taking medications that may interfere with the skin testing or block the skin test. We do blood testing, and that's where we can actually check for the allergy antibody, the IgE antibody, to that specific food protein. The gold standard, by gold standard we mean the ultimate test, what is the final test that will tell us someone has a food allergy or not, is a food challenge. Usually we're able to determine if someone has a food allergy by the skin test and the blood test and their history. That, in most cases, is sufficient. But sometimes, particularly in someone who's very allergic, they can sometimes get false reactions on their skin test. So they may not be true allergic to something that's popping up on their skin test. Or sometimes the blood test misses it. It's not 100%. It can miss a food allergy. So in those cases where we're not completely convinced and the history is a little bit vague, we could do a food challenge. And that's when we actually give them the food and see what happens. Now, of course, someone who's had a serious reaction, this is done in a hospital setting where they're monitored. Okay? But that's the ultimate. So this kind of, you can also kind of deduce from this that if you're suspicious about a food, you think I may be allergic to it, but if you've eaten it subsequent to your reaction, you're okay. You've already done your own food challenge. You've done the gold standard, so you're not allergic to that food. A food allergy is very consistent. Every time you eat it, you are going to react to it. Okay? There are some inappropriate food tests that are done, mainly by alternative practitioners. Many of them have their own beliefs or philosophies on what causes disease, and they like to blame foods for a lot of diseases. And so you may come across these kind of tests. Vega testing is commonly done, and actually this is the Vega test device, and it's basically a galvanometer. It kind of measures electric current. And what you do with this test is you hold one electrode right here. The patient holds this electrode. A food is kept here, and the person who's using the test will take this probe and touch you on your skin somewhere, and a little needle here will swing back and forth. Basically, when this needle touches you, you complete the circuit, so you are going to get a little swing anyways. But they use that to claim that whatever food they're putting on top of here is what you're allergic to. This test is very dependent on the person who's doing it. They can really influence the test. And usually people who get this testing done usually come out with a huge list of foods they're told they're allergic to. Some people like to believe in that kind of philosophy and it helps them out. But just kind of keep in mind, it's not a true food allergy test. It's not going to predict if someone's going to get a dangerous reaction or not get a dangerous reaction to a food. Neuromuscular testing has been done, and this is where the patient is told to hold a certain food in one hand, and the examiner pulls on the other arm. And depending on the resistance, they'll tell you if you're allergic to that food or not. So again, just based on belief. A common test that we're now seeing is a blood test for IgG to food. IgG is a different kind of antibody. It's mainly an antibody that helps us fight off infections, bacteria, viruses. We also produce IgG antibody to food proteins, but it's a normal phenomenon. Everyone produces it. All of us here in this room produce IgG to foods that we've eaten. So if you do a blood test to it, you're always going to pick up IgG in everyone. Okay, so this test has been done by some of the alternative practitioners, and again, you get a big list of foods that you're told you're allergic to. There's no conclusive study that has ever shown that those IgG antibodies are pathological, meaning that they cause disease. They're felt to be a normal phenomenon in everyone. But the test does come back positive, so a lot of people like it because it gives them an answer sometimes. But they may not really be not truly allergic to that food. So how do we treat food allergy? Well, the most important thing is to identify what you're allergic to so you can avoid it. At this point, we don't have a cure for food allergy. So it's simply identifying and avoiding. Okay? And that's the most important thing. People who have this condition need to inquire every time they're eating out at a restaurant, friends, relatives' place. We usually tell them to talk more to the cook or the chef, not just the server, because they're not responsible for food preparation. They should try to avoid, buffets or potluck dinners where you don't really know what's in the food or there's cross-contamination. The schools are very good now. They now have policies in place. And this actually happened because there was a death of a young girl in Ontario from food allergy several years ago. And after her death, there was a big campaign to have set policy. She died in her school. This cafeteria actually mislabeled the food that she had eaten and that she was allergic to, and she was misinformed about it. So from her death, there was a policy that was then developed in Ontario for all schools to have a policy for kids with food allergy, with life-threatening food allergy. So everyone, would identify which children in the school have food allergies, that people are trained how to use the EpiPen or other auto-injectors. And so that law was initially passed in Ontario, and now other provinces have adopted similar laws. So in BC, we've had one for the past few years, and many other provinces have also have these laws in place. So it really does make it easier for parents who have children with these severe allergies, that the school is now taking it more seriously and do have some kind of policy and plan. It's important to identify yourself as having a food allergy. If you were in a restaurant and you reacted, and it was a bad enough reaction that you lost consciousness and you rushed to the hospital, at least they know what's going on. I also tell patients to make sure that they have written down on their medical alert bracelet that they carry an EpiPen or a Twinject. So if there's someone with medical knowledge who comes to help them out, they were in a public place, they collapse from a food allergic reaction, someone reads that bracelet and sees, hey, they carry one of these devices, they can search in belongings, find it, and give it to them, and that could be life-saving. These devices I refer to are the EpiPen and Twinject. These are the two devices that we have in this province that, or in this country, that can deliver epinephrine through a spring-loaded needle. Epinephrine is a drug that can very rapidly reverse a dangerous food allergic reaction. It very effectively opens up the airways, increases blood pressure, decreases swelling. The only thing with these devices is that when it injects you with the epinephrine, that epinephrine is only in your system for about 10 minutes. So the purpose is just to buy you time to get to the hospital or call an ambulance. Okay? These things don't cure the reaction. They just temporarily reverse it. All right? The Twinject has 2 doses of epinephrine inside, which is why it's called Twinject. So you can use one injection, 10 minutes have gone by, your reaction comes back, you haven't made it to the hospital or an ambulance hasn't arrived, you can give yourself a second one. People who carry an EpiPen sometimes just keep 2 of them with them. Okay? In terms of future treatments for food allergy, there's a lot of research work being done into this. Now that the prevalence is increasing, a lot more research is being committed to this. You may have heard about desensitization in the media in the past year or so. Desensitization is when you expose someone to very small amounts of what they're allergic to, and they slowly become desensitized to that. Been doing it for decades, or almost close to a century now, with environmental allergies like pollen and dust mite through immunotherapy or allergy shots. It's been shown to be very effective for that. And it's recently been looked into to doing that with foods. So someone who's food allergic, for example, peanut allergic, they get exposed to very tiny amounts of peanuts slowly building up. And that kind of modulates or turns their immune system around a little bit, and it kind of down-regulates that allergy antibody, produces some protective immunological factors. But it's still experimental. There's a few centers in the US and in the UK that have done it. It has been successful in some of those cases where these children were successfully desensitized. But to maintain the desensitized state, you've got to continually be exposed to that food. So these children, for example, underwent peanut desensitization, got exposed to tiny amounts, built up, and then they have to continue to eat those peanuts every day to maintain the desensitized state. So it's not a cure for food allergy. It's just another way of managing it. By being exposed to a small handful of peanuts every day, they maintain that desensitized state. It doesn't mean they can go out and have a whole bunch of peanuts. It just means that if they get accidental exposure to small amounts, nothing's going to happen to them. Okay? That's the main thing. There are drugs that are being looked into that can have that same kind of effect, where it can kind of bring down the allergy antibody, so that if someone gets exposed to these small accidental exposures, they're not going to get the life-threatening reaction. It's easy to avoid a bowl of peanuts. It's very difficult to avoid peanut when it's a hidden ingredient in a food. So that's where the research is now looking into. So just to summarize now, allergies are very common. We are seeing a rise. We talked about some new manifestations with the eosinophilic esophagitis and the oral allergy syndrome. It's very important to be aware of what allergies are, okay, and it's important to make that diagnosis, particularly for food allergy, because of its implication. And then we've talked about some treatment options, and we'd be happy to discuss more about the treatment options during our open forum. Okay, thank you.